At the onset, I'll thank the team, Tony's, to invite me for such a nice wake-up call on the systemic disease. It's a nicely thought about CME done here. Today I'll be talking maybe it's like a fag end, so I'll just talk on the clinical trials on diabetic retinopathy. It's a huge and vast topic. I'll just cover the most important ones. The trials are basically divided into how the treatment went on from lasers to injections. The era of lasers was in the initial part where most of the trials were done. So I'll just explain two major trials, the DRS and ETDRS. These are basically based for whether lasers are important or not, whether they are beneficial or not, when to do and why to do. So this started in 1970s, and the main role of this study was to see whether it was helpful, any use in reducing visual loss. So the result of this trial was that PRP mainly reduced severe vision loss in at least 50% as compared to untreated eye. And thus came the definition of high-risk PDR, which was one of the outcomes of the DRS study. So as it was defined as NVD greater than or equal to 1/3 disc area, any NVD with vitreous hemorrhage, or NVE greater than or equal to half disc area with vitreous hemorrhage. So based on this trial, all high-risk PDR had great benefit from PRP, and there was no clear benefit when it comes to severe NPDRs or without high-risk characters. The next study was done around 10 to 15 years later, which was ETDRS, or early treatment of diabetic retinopathy study. So this had three main things to look into. The lasers, one is whether scatter PRP is useful or not. Second was for whether the macular laser was beneficial or not. Third wing was whether aspirin was useful in diabetic retinopathy or not. So the question was, as I told before, whether the efficacy, what was the best time to initiate, and what the natural history. And the result was aspirin, when it comes, had no effect on the progression of retinopathy, no increase or decrease in vitreous hemorrhage, whether you start or stop the treatment, did not affect the vision. When it comes to focal laser, it helped in reducing the visual loss, moderate visual loss, in about 50% of the patient. Thus came the definition of CSMA in the study, and this, I think so, you all will be knowing. And like DRS, ETDRS also told that there was significant reduction in severe visual loss when it comes to high-risk PDR. So these two are the main trials for the laser part, or the laser treatment. Next, the concept was how to prevent the progression of diabetic retinopathy when we see the systemic control for the patient. Thus came two large studies, the DCCT trial and the UK PDS. So DCCT is also known as, the full form is Diabetic Control and Complication Trial. So the outcome of this study was, if you give an intensive therapy, if you control the sugars significantly, there was a risk, the relative risk of developing retinopathy reduced by 76%. Not only this, the nephropathy as well as neuropathy also reduced. So this was quite a big significant study when it comes to control of systemic factor. The same thing was extended by UK PDS, or United Kingdom Prospective Diabetic Study. This study was done over a long period, 10 years, and it was one of the largest study done ever. So other than a strict control of sugars, they also have seen whether whether the BP control was also important. So this was quite a big landmark, mainly because of the duration and the number of patients involved. And they came out that 1% decrement of HbA1c level, or a stricter control, reduced around 31% the risk for retinopathy. The same thing was blood pressure control. The largest study was the DRCR NET protocol. So this was initially started for diabetic retinopathy, but later over the years, it was changed into many other retinal disease. Hence the name was changed from just a DRCR NET, it was changed to DRCR Retinal Network in somewhere in April 2019. So there are a number of studies starting from AA going to double digits of AA and AB and all. I'll not go into all of them, just few with their importance. Like protocol B was mainly to compare, at that time we had a grid laser or a macular laser and we didn't have injections. So next was IVTA had come. So they compared these two and found out that the focal or grid is more effective when you say protocol B is more effective and has fewer side effects when we compare to a preservative-free IVTA. At that time, the second thing what we used to do was to give a PST or a posterior subtenon tricot. So whether that was effective, and protocol E shown that it was unlikely to benefit in any of the patients. Protocol R was also significant. It is still significant now because lot of us give non-steroidal drug for most of our patients. So this protocol R is quite important if you go back and see. So they showed that non-steroidal, like what we prescribe, nepafenec for all of our patients, showed no significant improvement either in the visual acuity or OCT thickness or progression for involvement of DME. Protocol F, so there are multiple A, B, C, D, E. So each one, if you can remember, it will be very, very easy. To see whether you can do PRP in 1 sitting, 2 sitting, 3 sitting or 4 sitting. So we all confused at how much sitting you should do. This is a nice one, protocol F, whether they told that you can do in a single sitting if patient can tolerate. There is no difference in the OCT or visual acuity in any of the patient. Then came whether you can, the role of anti-VEGF, whether prompt PRP is as good as deferred PRP for PDRs. So the conclusion was you have a subset where you can give anti-VEGF, but the longest period what they have is 2 years. After that, what no one knows. So it's like an alternative to PRP, but however, you should be very selective, avoid anti-VEGF when there is substantial tractional component in PDR. You can prefer them as the initial approach whenever you have a DME. Protocol I was like to compare intravitreal 5 mg injection or 4 mg triamcinolone along with grid, and they found that in pseudophakic they can be more effective when you give tricot with prompt laser. Protocol W was whether you can give anti-VEGF to moderate or severe NPDR and prevent a clinically significant diabetic macular edema or PDR development in future. And they didn't find any much difference, and there was no improvement in the visual acuity also. I'll skip this. Just to give few other major studies about injections, because injection is the era where we are following. So just to remember, for as a PG, we can just remember that all the studies starting with R are related to ranibizumab, like Resolve, Restore, Rise and Ride. If you want to remember with Avastin or bevacizumab, you can remember as B or Bolt study. And all the V's are with aflibercept, which is Da Vinci, Vista, and Vivid. Thank you.